I don't need to do anything because I'm going to hand over to Chiquita Hansen, who's going to introduce her team and take us through another really exciting presentation. Thanks, Chiquita.
Thanks, Janine. Well, kia ora koutou. It's nothing like a Friday afternoon at 2 p.m. to talk to people. I arrived today at 12:19 and lunch was at 12:20, so I think my timing is absolutely impeccable. And Melanie Taylor's really worried because I've promised to talk for 3 minutes, if not 5, and I'm already taken up 1 minute by saying that, so she'll be getting extremely anxious. So I'm here just to provide an overview of our approach that we've had locally around long-term conditions. My name is Chiquita Hansen. I'm currently the Chief Executive for Think Hauora, formerly known as Central PHO. And to my left here, we have Dr. Claire Budge, who's our health researcher, and Melanie Taylor, who's our long-term condition advisor, nurse advisor. Did I get that right? I just had to remind them what their titles are, so I never call them by their titles. To me, they're Claire and Mel. So thanks very much for the opportunity, and I haven't worked out where I'm clicking, so I should have done that. Next, there we are. So first of all, our rohi, who and what we are. So who's been to Palmy North? Yeah! Woohoo, fantastic place. So we're the centre of the Mid-Central sort of District Health Board. We have 182,110 people. I'm not going to go over the slide in great depth, but the most important thing is we've actually learnt and actually have some engagement with communities, and we're starting to celebrate with them their successful things. So often when we talk about Otaki, we'll talk about its population of 9,000 and it's got 70% high health need. I now always say we have a population in Otaki of 7,000 population, and for NCA Level 2 Māori, they have the highest achievement across our rohi. Because we always describe our communities from a deficit lens, and it's so important that we think about the strength-based approach. This has been our journey. So when I say our, we're really lucky in our district. We have one district health board and one PHO, and we have worked really collectively together for a very, very long time. And many of us have been in the district for a long time, so we know each other. And the beauty of that, you can actually slap each other when you need to, but then you go and have a coffee afterwards. So we started in 2004 around primary healthcare. Developed our own strategy aligned to the ministry strategy, and then the population-based funding formula gave us $15 million. The board at the time threw that into primary healthcare. So we've been on this lovely, lovely road of a whole lot of new FTE, a whole lot of money, and it's all been framed up around long-term conditions. Chronic care model, Ed Wagner, everyone knows. I used to be called Nurse Wagner. Melanie Taylor is now Nurse Wagner. All our contracts that were rolled out were all within the long-term condition overall framework. So we've been busy with that strategy and the plans. We've gone from a cornered dairy to a sustainable general practice approach. We now have 7 integrated family healthcare centres across that 182,000. We got very caught up in the better, sooner, more convenient policy days, loved all that. Down the bottom, though, that's a really important part. You'll see each 2 or 3 years, it's a plus, plus, plus. So we start with something, we invested 17 new long-term condition FTE, then we thought about primary healthcare teams, mental health, child health, Pacifica Māori health and primary healthcare programs. Then the system enables older persons, whānau order, integrated family healthcare centres. I'm proud as CEO of PHO that we fund Māori iwi providers 7 whānau order navigators. We're the only PHO across Aotearoa that I believe we actually fund hard green dollars into Māori iwi, and I think it's really important. Last 3 years, we've very focused on access, equity, integration, partnering, and then just last year we changed our name from Central PHO to Think Hauora. Our new strategy, if you're ever bored one night and want to read the most beautiful document, do download our strategy, and it's all based on the concept of weaving, and that's based on harekeke, which is our indigenous plant here in Aotearoa, and our proverb that lines next to that. So weaving for us is about whānau ora. It is about achieving wellbeing, equity, the people, community voice, and data-driven. And that's what we're going to hear very shortly, is about some people's voices and the research that we've been doing for the last 3 years. It's been really important on our journey to actually do some research and do some PDSA. I often say PDSA is please do something, anything. Because if we don't do anything, we're just going to get stuck in status quo. So we've had lots of little R and lots of quality improvement, but this is our example of our big R, so our research. And it's so fantastic to have team members that actually do what they've been charged to do and not like me and end up doing anything than what I was actually supposed to do. Then we're really focused on access, value, innovation, networking and growth. We have adopted the quadruple aim. Our language around the quadruple aim is really important though. We are really interested in affordable care, and I know that's often value. We're really interested in excellent outcomes, excellent experience for those we serve, because we are privileged. We are so privileged that we get to serve our communities, and then excellent experience for providers. And I heard the word joy earlier, and it's so important we get joy back into our practice. We've also adopted the whānau order outcomes. So they're on the right, and I've heard a lot, I've only been here since 12-19, but I have heard a lot about the importance of connecting with our communities for wellbeing and looking at different ways of measuring how we're being successful or not. I'm now going to hand over to Mel Taylor, and I think I didn't go too over.
Thank you. I'm talking on behalf of all the research team, which Chiquita is part of our team. Mataroa Ma and Falole Whai are also members of our team. So our presentation is called Hearing Their Voices, the views of people with long-term conditions, and we're particularly interested in self-management support. So this is what we're going to cover in this session. And you can see there the aim of our research. And we're aware that the term self-management is often, it's used in the literature and it's often implied an individualistic approach. However, for most people, Māori and Pacific especially, it includes care and support from whānau, family, friends and neighbours. Hence, that's how we use it in our study. So today I'm going to share about the patient arm of the study, because we also looked at practitioners as well. So for our recruitment, at that time, Compass Health was our MSO, and we asked them to find us all the people that had had a comprehensive health assessment for Māori and Pacific people in the last 3 years, and for others in the last 2 years. Now, the health assessment basically tells us that people are registered with a general practice and they're receiving some kind of package of care for long-term condition management, so they have at least one long-term condition and they're requiring some support with self-management. In our consent forms, we asked what conditions people had, because we wanted to add to our questionnaires a range of more common chronic conditions, long-term conditions, and we didn't want it to get too long, but we particularly wanted to look at some specific conditions such as pain, diabetes, etc. Even despite that, for some clients with comorbidities, it ended up being 19 pages long. So overall, we did paper and online questionnaires. The online one was not taken up very well, and overall response rate of 21%, and 569 people returned their questionnaires for year one. You'll hear more about this later, but in year two we also interviewed 32 volunteers for face-to-face interviews. So in our annual questionnaire, we included the following. Health status was measured using the patient reported outcome measure, or the PROMIS. It has 10 items and give an overall measure of general health, mental health and physical health summaries. Healthy behaviours: eating, drinking, not smoking, exercise, taking medicines and planning nice things to do were included. Patient activation we'll hear more about, that's also known as the PAM, and experiences with doctors and nurses in general practice. Here we used the General Practice Assessment Questionnaire and added a few questions of our own. So if we look at the demographics of the people who did the questionnaire, the whole group, there were more women than men. There were 15% Māori and 1% Pacific. 2/3 were 65 or older, 2/3 were retired, and 2/3 lived at home or with others. Over 1/3 had no school qualifications. Income adequacy was measured using having enough money to meet everyday needs, such as accommodation, food, clothing, and other necessities. Housing problems, there were 5 options: damp, hard to keep warm, pests, repairs needed, or too small. So the main long-term conditions for this group of 569 people were pain, hypertension, diabetes, and respiratory conditions. What is notable here, this is self-reported conditions, that 19% reported anxiety or depression related to their long-term conditions. Other conditions not listed here include things such as gout, Parkinson's, stroke, diverticulitis, and osteoporosis. So the total number of long-term conditions ranged from 0 to 11, with a mean of 3.3. In year 3, we added an additional question, and we asked people, did one long-term condition have more impact on them than others? And 3/4 of the people said yes. However, when it came to descriptions of how that impact had happened, most people highlighted more than one long-term condition as being problematic, and which highlights the complexity and impact of comorbidity. Both physical and emotional impacts were included. So in year 2, we did some interviews. We invited people in year 1 if anyone was interested in having some interviews with us, and we got an overwhelmingly positive response. We selected people across the region with different demographic features just to make sure we got a good representation. So today we'll speak about the non-Maori interviews, because we felt for people who were Māori that they were better interviewed by Māori researchers who could kōrero with them. And that work is yet to be published, and we asked Massey University to do that work for us. So we were interested in how people live with their long-term conditions and their experiences of care. We were also particularly interested in the general practice consult and how health advice was received. So when we look at this group of the 32 participants, more women than men participated. Most were New Zealand European. The age split was pretty even from under 65 and over 65. Most people were retired and lived with others. Most said that their income was not enough or just enough, and 1/3 of the group had no support other than that provided through healthcare. Thanks. The most common long-term condition for this group were diabetes and pain, with the range of long-term conditions being 1 to 7, with a mean of 3.7. We asked people to report on the impact of their long-term conditions on their quality of life. Thank you. And this ranged from 0 to 10, with a mean of 6.8. The interview themes. These are the key themes that came out of the interviews, and people provided examples of how they manage these aspects of living with their long-term condition. And Claire and I are both writing a publication about this at the moment. Here we start with some illustrative quotes. We learned that acceptance took time. And people need to accept their condition in order to make life work. Accepting help from others was actually incredibly difficult, and as people really wanted to retain their independence. If help was needed, it was far more acceptable being from family than from people that they didn't know. And health advice was more likely to be accepted from health practitioners who knew them and in the context of shared decision making. Making it work. Again, some illustrative examples. Participants shared numerous ways that they make life work. For example, in daily life, activities were often shared with family. For example, a husband got up earlier than his wife to give her pain relief, so then she could get up and start her day with less pain. Or changing roles. For example, a husband who traditionally did outside work, now participating with work inside the home. The coping mechanisms often cited were things such as resting and pacing yourself were often shared. What's of note here is the number of people that had dependent children or other family members that required them to be in a caregiving role. So not only did they have these conditions, but they also had to care for others. And often, the people that often provided care within the family had long-term conditions themselves. In health relationships, people shared how they took ownership and the lead in their interactions. And that for some, it means something as simple as being proactive in booking their appointment for 3 months' time to get their own practitioner. Hold on. Just 1 minute. I've mucked up. Work with me. People wanted their practitioners to work with them, and this had 4 components. They want people to know me, listen to me, believe me, and partner me. So know me was particularly important, and people didn't like using other practitioners or locums. Patients felt that practitioners that knew them would go the extra mile for them and that they would get more from them. They also believed that they get more from the consult because the person that knew them could get straight to the issue at hand. And I wonder, perhaps as the healthcare demand changes, perhaps this is the real question that general practice needs to answer, is how can we as a practice help people to feel that whoever sees them knows enough about them and that their needs can be met. Self-care challenges. Again, we added this in to year 3. After the interviews, we realised that there was a lot of, from hearing from the interviews, that there were a lot of challenges people were facing. So we asked them the question, what self-care challenges do you face? And then we also asked them after that what was the biggest one. So for the main group, that was a good thing. Exercise, pain, mobility, sleeping and home garden maintenance were the major challenge and posed to more than 40% of the group. When we looked specifically at Māori, we found the top challenges to be exercise, pain and sleeping, which were all over 50%, and being overweight and not having enough money, over 40%. Interestingly, another part of our questionnaire asked people to rate aspects of their GP consults in regards to practitioners learning and helping with their social support needs. And despite mobility and social assistance, home garden maintenance, being significant challenges, people did not see this to be part of the general or the practitioner's role, so didn't share. What also is interesting here is that 15% of the group said that communicating with health professionals was difficult and a challenge. So when we ran independent T-tests, it showed, on average, more self-care challenges are faced by women than men, by Māori than non-Māori, and that the number of challenges decrease as the income increases. Interactions with the general practice team. So again, some participant advice, giving each other advice, what they could do. So there were 14 statements here that rated health practitioner behaviour from very poor to excellent. So an example is, when you see your doctor at general practice, how good are they at spending enough time with you? Other behaviours are summarised in this slide. Participants were asked to rate doctors and nurses separately. So we'll look at the ratings across the 3 years. All but one item was scored in the 4s. The range for doctors was 4.2 to 4.9 and nurses 4.3 to 5. So that's good to very good on average. However, what we noted was the aspects of the consult that got the highest ratings are aspects of any sort of consultation. However, those that were rated less well were more specific to meet the needs of people with long-term conditions. So we'll look at the highest. For doctors, making people feel comfortable in physical exams, knowing about medical history and current treatment, explaining things clearly. And for nurses, they were rated as good listeners in making people feel comfortable. The lowest ratings were knowing patients as people, learning about support needs, and spending enough time for doctors, and for nurses, involving whānau in decision-making. Care planning and health goal support. Participants were asked about the care planning and support for health goals separately. Here we present Year 1 data. Only 1/5 of our participants had a care plan, and most didn't, and 16% were unsure. Of those with a care plan, most helped to develop it and used it day to day. Review of care plans wasn't always done, and for those who had it reviewed, 40% said it was done quarterly, and 30% said annually or less. Half of the group said that they had practitioner support for health goals, with 30% saying they had no health goals. So this table shows the difference in the mean scores for Māori and non-Māori who indicated they did or did not have a care plan. For non-Māori, all of these differences were significant. For Māori, the general practice variables were significant for those with a care plan. However, looking at patient activation scores for Māori, these would have been significant if the sample size had been bigger. We look now at support and no support for health goals for Māori and non-Māori. This shows that all comparisons here were significant for non-Māori, and mental health and general practice variables were significant for Māori. Again, we see the smaller sample size affects the significance, as they are similar differences for both ethnicities apart from physical health. So overall, there is advantages to having written care plans, especially for management at home, where people can be supported with written information about what to do day to day and what to do about a change in health. However, having practitioner support for health goals was even more beneficial. Changes to general practice consults. Again, we added this in year 3 after the interviews. We asked what would they change if they could about their general practice consult. And these are the main themes in the responses. We do need to note here about 200 people didn't answer this question, and of those who did, 50 didn't know if they were didn't know how to what they would change or were happy with the service. So the time and the busyness of the practice. People often talked about being rushed or feeling like a nuisance. One person said, "Stop making me feel like I'm taking up their time and then wanting me out, even though I haven't been there for the allotted time." Another said, "I've answered fair to many of the questions, read the doctor, because I feel she does not have enough time to spend with each patient. Her practice is big and she would be trying to see so many people. I know she's a good and caring doctor, but time is not on her side." So what most people wanted was more allocated time per consult, having the full 15 minutes, and practitioners to read their notes and be prepared for their visits and then record accurately post-visit. Another thing people talked about a lot was wasted patient time, particularly in the waiting room as they waited and waited and waited for their turn. Cost. People perceived that there were excessive costs associated with consultations, the other services general practice provide, repeat prescriptions, and collecting medicines. Some people shared that their community service card didn't appear to make little difference for either being seen or collecting medicines. Another said costs mount up, especially when the doctor and the nurse collaborate and you end up with a double charge. And the double appointment fee meant someone was always financially backpedalling. Another said, "The cost, in 4 weeks I have spent $280 on visits." A number noted that you pay for everything in general practice. For example, having your blood pressure, weight, or blood test done, and they looked for other options. So one person shared how they used the local pharmacy to check their blood pressure because it was free, and another client talked about using their St. John alarm for having the service that they needed without having to pay. And a couple suggested that long-term condition care should be funded. And as a matter of interest, we looked at the cost and access of how many places are taking new patients in our region. And what we found is that most practices charged over $40, so it's understandable that people were reluctant to book another appointment or more frequent appointments or double appointments. And I know some of you guys will be going, "Gosh, that's cheap," because I'm from Wellington and that is cheap. But, you know, for these clients it was significant. So in the general practice wider team and setting, people wanted care consistency, and having their own GP and nurses really important to them. Extended wait times meant that they had to see other practitioners or locums, and in this case they wanted their own practitioner to have some input into that consultation. Follow-up was viewed as really important, and to them showed them that practitioners were cared about their progress and were interested. And passing of blood tests was also seen to be particularly important. Receptionists were commented on as people wanted them to be more helpful in arranging appointments and repeat prescriptions. Ongoing prescription errors were particularly problematic, and so were billing issues that caused frustration. And ideas to improve the physical environment and other service improvement ideas came forward. And one person said, 4 GP practices built 1 new clinic. Big is not better. Medication. Again, some quotes from our participants. We asked people how many days a week they took their medications as prescribed, and 90 to 93% said 7 days per week, which is much higher than what the literature tells us. We did a breakdown by ethnicity over the years, and we found that for non-Maori it was relatively the same. However, for Māori it had dropped 10% from 2017 to 2018. We then asked about medication collection. Did they collect all of their medicines from the pharmacy? And again, 90% said yes. If no, there were these 4 options. And the main reason people said was leftover medicines. And this may be due to them not taking the medicine as regularly as prescribed, or they may be people who have just-in-case medicine, such as pain medicine. However, this scenario is more likely in the next question. We asked whether they use all the medicine they collect from the pharmacy. Again, the main reason was that if they didn't, was that they had leftover medicines available to take. But what's striking here is the number of people who collect and often pay for the medicine, the surcharge, and this was 17% by 2018, even though they have a supply or they don't like it or don't need it. And we wonder how many prescribers are aware that this is the case. So our message is getting through to collect your medicines from pharmacy. Patient activation. So this is described by Hibbard and colleagues as an individual's knowledge, skills and confidence for managing their health and health care. Again, some illustrative quotes that demonstrate activation. So patient activation has 13 statements, and people are asked to indicate their level of agreement from 1, strongly agree, to 4, agree strongly. They're scored from 1 to 4, and there is a not applicable option. Scores calculated if 10 of the 13 questions are answered. So the PAM score is used to position an individual on one of 4 hierarchical levels. Previous research has shown that people with high activation understand their role in the care process and are able to fulfil that role, but are able to do that, but are also more likely to engage in positive health and self-management behaviours. So in the next few slides, we will show how mean scores on a range of health and general practice variables vary according to level of activation. Physical and mental health increase as activation increase. General practice team support and quality of life are measured on a 0 to 10 scale, the purple being the mean level of support from the general practice team. The others are quality of life, blue being life satisfaction, orange being perceived control over life, and green being the effect of long-term conditions on quality of life. And all scores are more positive at higher levels of activation. Interactions with GPs and nurses and general health. The blue and the orange are the mean interactions of doctors and nurses in general practice, scored on a scale of 1 to 6. Purple are the mean ratings of health in general and can range from 1 to 5, poor to excellent. And again, all are more positive at higher levels of activation. So in summary, patient activation is associated with a more positive experience with doctors and nurses, more support for self-management, better reported health status and quality of life. And health activation can be increased, and increases are associated with better outcomes. So, practice points. These recommendations outline the path that we as a region need to take in our journey to improve the health and well-being of people with long-term condition. Many of the points will also reflect what is needed from a national perspective. It is my experience that as healthcare changes, care changes are often driven from health service requirements. Today, I urge you to consider these recommendations after hearing the participants' voices. And I'd like to acknowledge all the people that took part in our team and thank Hauora for funding this piece of work. Thank you.
Okay, great. Thanks so much, team. We've got time for a couple of questions.
And Claire's going to answer them because she hasn't spoken yet.
Yeah.
One more. That one. Mia.
Thanks so much, team. And really great to hear. My question, of course, is around language. I'm just wondering how you find the concept of patient activation. When you look at the questions that the clients answer when they're answering that form, I think the first one from memory is all about, I feel in control of my, and I feel I can influence my. And that's part of the measure. And again, I just wonder, some of the people that I would know who are in a place of learned hopelessness, helplessness, or fatalism, again, it seems like we're talking about doing to as opposed to other. I'd just appreciate your comment.
It is a problem. Sorry. It can be a problem when you pick up a standardised measure and you're not able to make any changes to it. And I had some initial reluctance in using the measure, partly because it costs so much, and I couldn't believe it. But I've actually become more impressed with Insignia Health, who manage the whole process, as I've looked at what they actually offer. Because to start off with, I thought that the fee for the using the measure was all about helping to improve the measure, and I looked at it over a number of years and nothing changed. And I thought, so where's this money going? But in actual fact, they do provide an awful lot of support and coaching and whatever for people who want to enhance patient activation. But in terms of your question, the first question is all around whether or not people take responsibility for their health. And I think that is a key thing, because if people are not prepared to take any responsibility at all and assume that health practitioners are going to do everything for them, they're really starting from behind, because people do need to learn to self-manage in some shape or form, even if it's only getting a better understanding of your conditions and how they might influence you, and how what you do might influence your health in the future and your trajectory, etc. So I think, like all measures, it does assume the same interpretation from different people, which isn't going to be the case, but it's the same with any measure. It's a problem with doing quantitative measurement. But overall, it seems to work so well that there has to be something behind this that is worth supporting and measuring and encouraging.
Any more questions?
Thank you for the presentation. I'm interested in, I noted one of the points in there was that people really wanted to see their GP or nurse. You know, they were willing to wait in order to see the people that they knew. Were any of them working with a wider care team? So could they identify a whole lot of people that they considered to be their team?
Not a lot emerged about that. We didn't specifically ask about teams as such, but we did ask people to rate the interactions they had with both doctors and nurses. But there were a lot of people who were working with particularly advanced nurses, and that came through in the interviews specifically, that they felt really, really well catered for, and they were very happy. Some of them had been through several GPs and felt that they weren't really having the support that they needed or the understanding that they needed, but they found it with an advanced practice nurse. So there was that sort of element of nurses and doctors providing a different type of care and that sort of teamwork. Yeah.
Will these results be available for others to have a look at? Because there's a lot of depth in the slides here.
We published one paper on care planning last year that was in the Kaitiaki Research Journal. We've had a paper accepted for the New Zealand Medical Journal on patient activation. We have another paper on pain, which is in the publication process somewhere. We're still waiting. And we're presenting these results at the Wonka conference, and that's more about patient activation. That's in April. So yeah, we're continuing to try and put more information out there, and there's going to be a series in Kaitiaki Journal for nurses trying to encourage sort of practical things that they can do based on our results.
Well, thank you all so much. I really appreciate your input there, and look forward to seeing those papers as they come out. Thank you.